Okay, Assalamualaikum and hello everyone, all oncologists all over Malaysia. So welcome to the first Malaysian Oncologist Tumour Board, done under the auspices of Malaysian Oncological Society as well as with funds given by Zulik Pharma. So the objective of this MDT Tumour Board is to discuss our treatment planning and execution. It's purely educational, and we are balancing data or evidence with knowledge, experience, and also applicability, and also thinking about access in each of our respective places. So it's also like an update on any emerging strategies in cancer management. So today we have a few cases to present to you for discussion. We of course I have a panelist that is representative of all the sectors in Malaysia today to be with us. So we will have Dr. Darren from Sabah, from Private Center Sabah. We have Dr. Anna Lim from IKN, and then we have Dr. Doris from all the way from Penang, myself, as well as Dr. Esnal from HKL. So we can just call each other just by our names. So I think without further ado, we shall begin with the case discussion. Maybe I would like I can share my screen now. Sorry. Okay, so my first case is a 70-year-old businesswoman. So she presented last year with a severe back pain to the emergency department, and this was associated with a mild numbness at her left upper limb. Her pain score was actually very severe, 9/10, although her neurological examination was actually intact. So she has a past medical history of hypertension and diabetes, and also hyperlipidemia and gastritis. There is no family history of cancer. And she was also somebody who's very fit and active prior to her presentation, because she's somebody who actually goes to feed the homeless in the soup kitchen business over KL. So on examination, actually she was found to have an ulcerating breast mass that was locally advanced. That was also associated with a palpable axillary as well as supraclavicular lymph node. So because of that, the doctors who saw her proceeded to do a CT scan thorax of and abdomen. And this showed the destructive bony lesions, as you can see there, at the C7, T5 as well as T12. And there was also epidural soft tissue component from T1 to T5 with cord compression at these levels, mostly marked at T2. And these lytic lesions are present also in the manubrium and several of her ribs. So this is, bear in mind, this is actually CT scan. So as you could see, there's also this huge multifocal irregular right breast tumor with skin thickening and ulcers that we knew from the physical examination. And naturally, there is a core needle biopsy was carried out, and she's diagnosed to have grade 2 infiltrating ductal carcinoma. The Ki-67 was 20%. It was ER/PR strong positive. The all-rate score was 8/8, and her HER2 was actually 0. So her blood parameters, the liver function test, the renal profile, the calcium were all within normal limits, and her CA was just 45 nanogram per mil. So essentially, this lady, who was a 70-year-old with who was active before the presentation, has diabetes and hypertension, and now has been diagnosed with de novo metastatic HER2 negative, hormone receptor positive, right breast cancer, and she also has this what we consider as impending cord compression. So she was discussed initially. Basically, she was managed by multiple, specialists. She saw a spine surgeon, she saw a pain specialist, as well as a palliative care specialist, breast surgeon, and oncologist. And it was decided that she was not required to do a mastectomy because it doesn't improve survival. And because of her multiple spine involvement, the spine surgeon has ruled her cord compression to be inoperable. An MRI was not done because the patient did not want it, and because of clinically she's not having any neurological deterioration. So she has had her pain controlled medically, and she wears a spine brace, and has physiotherapy and palliative radiotherapy carried out for her. So she's now, ECOG 0, 1 to 2. So if I may now invite the panelists to have a discussion about how we would, move on from here. So may I get maybe Esna to give your opinion about how to move hereafter.
Hi,
So,
Dr. Masha.
hi.
Yeah, okay. So I think this patient is impending cord compression. So, but unfortunately, the lesion is inoperable. I would say that even though this is not considered visceral crisis, but the nature of the disease and the complication that the patient might have if she ever develop cord compression is very significantly going to affect the patient's quality of life. So I would consider this patient as in crisis. But I would say that the treatment in this case, I would probably go for endocrine therapy with CDK4/6 inhibitor rather than chemotherapy.
Do you have any choices as per what type of CDK4/6 inhibitor that you may want to pursue in her case?
Any the options of CDK4/6, you mean?
Yeah.
At this moment, no. Yeah, I think I'll go with whichever more affordable for the patient.
No, sorry. I mean, which CDK4/6 would you choose, Esna?
I'll go for ribociclib and letrozole.
Okay. Okay, thank you. What about the other panelists? Maybe Doris, Darren, or Anna? Would you consider this as an organ crisis? Or like, organ compromise, I would say.
Hi, Dr. Mastura. So I think that this patient, when it's really up to the cord compression, I think impending cord comp, even though by definition it's not really a visceral crisis, but I think that I agree with what Esna said. So it would definitely affect her subsequently when it comes in terms of the performance status and the subsequent management. Yeah. In that sense, I think that is also like a crisis. Yeah, I would agree with the use of the CDK4/6 inhibitor with the aromatase inhibitor as the first line of treatment.
Okay. So for those who are, if any of you that are doing clinical trials or know about clinical trials, are there any clinical trials that are like, that we have in Malaysia that is suitable for patients like this?
I think at this moment we do actually have, or no, but that patient, there's one clinical trial currently ongoing in IKN, right? But that is patients who progress after adjuvant treatment. So so they will check the PIK3CA mutations, and the patient might have abemaciclib plus some IP. But that is only for those who are progressing on adjuvant treatment. So this patient is still novel metastatic. I do not know any clinical trials ongoing that's suitable for her.
Okay. So, okay, if I can move along. So I agree with everyone that in this patient where, it's like impending cord compression, it's not neurologically compromised. So I would also consider CDK4/6 inhibitor in her case. But who would actually consider just a hormonal treatment for her? I mean, we know about the SONIA trial, right? Where in the SONIA trial, it was actually shown that hormonal therapy followed by CDK4/6 inhibitor and hormonal treatment versus CDK4/6 inhibitor in the first line setting followed by hormonal treatment, which is fulvestrant after that, result in almost similar outcome. So Darren, can I get your opinion on this? I mean, in this case, with this kind of presentation, would you want to just give hormonal single agent?
Thanks, Mastura. I think it is an option, but we want a quick response here, as Anna and have said. So I think in order to get a earlier response and a higher chance of response, we know from all the trials of all the 3 agents, that we get a better response, longer PFS, and a higher chance of response from all the 3 combination agents. So I would go for a combination. And I think she should be able to tolerate it even at 70. Thanks.
Agree. Okay, so I'll move along. Thank you for all the opinions. Okay, maybe I can ask Doris on her thoughts on upfront genomic analysis in a patient with de novo metastatic breast cancer like this. I mean, she didn't have any family history of cancer. She's 70, you know. So do you do a germline BRCA in her case, or do you do upfront NGS?
Probably for a 70-year-old with no family history, it wouldn't be my first go-to lah. Number one, also to counsel a 70-year-old for her to understand the the indication for a BRCA testing. I think it's also a very difficult task. But I think for this case upfront, maybe I wouldn't do an upfront germline BRCA testing or even an NGS, because it does look like a straightforward where you would start a CDK plus hormones.
All right, agree. Any other opinion maybe with regards to these two? Okay, none. All right, so now we can go next. Yeah. Okay, so sorry. So this is basically the treatment option. I think for our junior colleagues that are listening. So basically, this is a de novo metastatic breast cancer. So usually de novo metastatic breast cancer, we will consider them to be endocrine sensitive because they shouldn't have any problem with resistance. So we look at their disease activity, their disease load, their symptoms. If they are younger and they have biomarkers such as BRCA, we also look at that, and we try to see whether they are in visceral crisis or not. If they're not of this impending but still can try endocrine therapy, then of course we would consider first-line treatment with a combination strategy. If you're doing hormonal endocrine therapy, then CDK4/6 inhibitor and AI would be our choice. But say that you need to give them chemotherapy because the patient cannot afford something like that. I agree with Dr. Darren, which is a combined chemotherapy strategy will give you the better response and improve PFS compared to just a single agent. So, but then of course, once you are able to stabilize the patient, able to get the disease to be controlled, then you can switch the patient to endocrine treatment without having to complete the chemotherapy. And if let's say the patient is on endocrine therapy, then with response, then you go next. And we try to give the patients endocrine manipulation rather than switching, unless there are elements of them being refractory or maybe having a very rapidly progressive disease where you have to switch to a different strategy. There are a lot of drugs at the moment in the armamentarium of treating these patients with metastatic breast cancer or hormone receptor positive, HER2 negative, and one of it is clinical trials, and that's why we always try to consider a patient to go into clinical trial if possible, right? So so this is just to further understand that people have actually looked at comparing in such patients between CDK4/6 inhibitor versus the combination chemotherapy strategy if they have aggressive disease or including those with visceral crisis. So the Right Choice study was a phase 2 study that actually looked at this patient population, and patients who have symptomatic visceral metastasis, rapid disease progression, or impending visceral compromise, or markedly symptomatic non-visceral disease were randomized to receive ribociclib versus combination chemotherapy of the physician's choice, and then they look at what are the endpoints that they look at. So true enough that the study, although the study was considered quite early, the overall survival data is not mature yet, but at median follow-up of about 2 years, the study results have been presented, where you could see that first-line ribociclib and endocrine therapy achieve this statistically significant PFS benefit of about 1 year over combination chemotherapy. And you can see, if let's say we are afraid that we fear that, oh, I'm taking hormonal therapy, maybe I won't get the response so fast, right? But the objective response rate between the CDK4/6 inhibitor and chemotherapy is almost the same, and the time to treatment response is also the same. So we know that this is a very, very valid strategy. And when you look at toxicity compared with the CDK4/6 inhibitor, the combination chemotherapy was associated with higher rates of treatment-related AEs, many of which impact the patient's quality of life. I think Esnal knows this because this is Esnal's trial. So this patient had the treatment, she had palliative radiotherapy to the affected spine metastasis. Then she had palbociclib at 125 milligram OD and letrozole, as well as denosumab. And the reason why I gave palbociclib is because the patient has hypertension and diabetes, and she's also an elderly lady. And she has gastritis as well. So I was a bit concerned with the QT prolongation in her if I use ribociclib as per the first choice strategy. And also she has a gastritis. So often when I give my patients ribociclib, sometimes they do complain of an abdominal discomfort, especially when they take it on very light meal. So for maybe if for the panelists, right, may I just ask your experience with ribociclib or maybe palbociclib with regards to patients' side effect profile? So who want to go first? Maybe Doris?
So you're asking just ribociclib or in general
Like, yeah, do you get my same concern, especially in elderly patient, where I don't want them to get gastric discomfort or QT prolongation with the treatment, especially in this scenario where she's, she has a lot of pain and she's going to take a lot of medicines. That's the reason why I chose
my
palbo.
experience with the palbo and ribociclib, actually, I don't think my patients have that much gastric discomfort as opposed to abemaciclib. Quite often my abema patients will have nausea, gastric bloating, and things like that. But the palbo and ribociclib actually not too bad. I mean, so far I don't have much problems with gastritis or this bloating. So maybe that for me may not be the thing. But if liver impairment or like underlying hepatitis, or sometimes they come in with this kind of like borderline GGT and things like that, then maybe I would consider palbociclib rather than ribociclib. But I know about all these cardiac assessment and things like that, but actually I've never seen any prolonged QT in ribociclib until now. So I only do one assessment. Don't tell.
Okay.
I don't really do that typical 6-week assessment anymore. I'm not sure. Is that how your practice is also? Do you still follow the 6-weekly cardiac assessment and all? But gastric, I don't see much problems with the ribo or palbo.
From the study we did see, because I did complement study, we did see the QT prolongation. We also having Serena 4 study where we also look at that, but that one is palbociclib, but we still also look at that. But maybe I can get Darren to comment on this.
Gosh, I'm in trouble now because because the drug companies are not going to like which one I say is the best.
No, this is among us only, so don't worry. No drug companies involved.
I really think there are a couple of options, and really we need to discuss all the options with the patient and let the patient decide. That's how I put it. Abi and palbo ribo, quite easy to differentiate side effect wise and all that. Taking 3 weeks, 1 week off, taking continuously twice a day. I think those are patient decisions, what they want to do. And I leave that to the patient. In terms of side effect profile and things, I do have a little bit more concern with toxicity with ribo compared to palbo. I've seen a little bit more liver dysfunction, patients not being able to tolerate it. QTC does prolong, but I haven't had to stop anyone on ribo because of QTC prolongation so far. So I think it's easier to manage in terms of dose reduction from 3 tablets to 2 tablets. So that's an advantage of ribo. And ultimately, I think which company annoys you with their programs is also very important. So a lot of issues, and I'll leave it with the patient to decide. Thanks.
Okay, thank you so much. Okay, so I'll move along. Okay, so I think that's in the chat group. I think somebody says something about Capitello 292. That's the clinical trial of fulvestrant and CDK4/6 inhibitor. So maybe we can check the MOS website to see which hospital has that trial. So I'll move along. So at 8 weeks assessment, there was a significant reduction in size of the breast lesion with healing of the breast ulcer and clinical improvements in terms of her bone pains. And then she also had very little toxicities, grade 1 neutropenia, anemia, fatigue, nausea, and decreased appetite. Okay, so sorry, I'm getting this. Sorry, may I just stop us for a while? Gordon, are we having problem with the logging system? Because a lot of members are telling me that they get logged out. Gordon, can you hear me?
Yes, I can. Let me check on this. You can just continue with the session first.
Yeah, so maybe you can give some of us the link to join, and then they can actually share it to the Malaysian oncologist group. Is that okay?
No worries. Yes, no worries.
Thank you. Okay, so move along, right. Okay, so this patient though, she's happy, her breast mass is better, but then after 2 months she has this I missed the chest x-ray, sorry. So she actually has another chest x-ray done because she presented to the ED with breathlessness as well as dry cough, but there was no fever. So the chest x-ray showed very, very mild sort of ground glass opacity, which raised the question of whether she had pneumonitis at this juncture. She has just taken the drug for 2 months. So then I proceeded to do high resolution CT scan that did show this multiple new patchy and confirmed ground glass opacity in bilateral lung fields, suggestive of this ILD, or acute interstitial lung disease. So her palbociclib was naturally withheld. Of course, she was admitted, but she was not in ICU or CCU. She just managed in normal ward with IV steroids, IV antibiotics, oxygen. She had chest physiotherapy and nebulizer, co-managed with our chest physician, and she recovered completely after about 1.5 weeks, like that. So can I ask the panelists, right? What would you do at this juncture? The patient has had pneumonitis despite the good response, but managed to actually resolve after such a short duration of time. So have you experienced pneumonitis with CDK4/6 inhibitor, because it's considered to be rare? So anyone, maybe Esnal, because you did the first choice study, do you have any pneumonitis case?
Yeah, fortunately in the right choice, I don't see any pneumonitis, but I do have patients on palbociclib who developed shortness of breath and reduced effort tolerance after 1 year of responding to palbociclib. But the CT scan shows ground glass appearance with also a few lung nodules. So at a point of time, we tried to rule out infections. All it was negative. We didn't do any biopsy of the lung nodules, but because of the presence of the lung nodule, I deem it as a disease progression. So we stopped the palbociclib and the tretol and changed to fulvestrant after discussion, because patients do not have PIK3CA was also negative. So, but after fulvestrant, the next CT scan of 2 months, the ground glass appearance disappeared. Completely disappear, but the lung nodule slightly is about the stable size. So at that point of time, then I'm thinking that maybe that ground glass appearance is actually a pneumonitis changes, but resolved with just a conservative treatment. I didn't even start any steroid at the point in time because the patient's symptoms is not really bad. It's only shortness of breath on addition. But I do think that is the only pneumonitis cases that I can think of, and then resolve without any steroid therapy.
Okay, I've probably seen 2 after using it for 2015, maybe 2 or maybe 3. What about Darren, or maybe Anna? Anna, have you actually come across pneumonitis from this?
Hi, Dr. Basra. I haven't encountered any case of pneumonitis, but I think in this case, because I noticed that the patient already had received the radiotherapy to the spine, so one of the things that I think may consider is that
Agreed.
also it might be also related to the radiation. Yeah, so actually I managed to find one case report also with the CDK4/6 inhibitor. So the patient has already received the palliative radiotherapy that to the spine also. Yeah, so subsequently I think that is one of the
Increase the risk. No? Understand. Okay. So maybe in terms of monitoring those patients who have received radiation would be where we would, have more alertness towards the age as well as maybe concomitant comorbidities and so on and so forth. Yeah. Okay. So now, she has got good response. So would you re-challenge the drug or maybe give it a lower dose? She had 125. So do you, reduce the dose to 100, Anna?
yes, I think I would reduce the dose to 100.
Okay. What about the other panelists, Doris or Darren or Asnal?
I have a question. Would you try a different CDK?
So that's also the question that I put up there, whether we want to change the CDK to ribociclib or abemaciclib. Sorry? So Darren?
Sorry, me, is it?
Yeah, anyone.
Oh, okay. Yeah, I mean, I think the fact that it actually responded very fast, 1.5 weeks is already resolved. I assume, is it clinical or do you do a CT scan to see the changes it has resolved?
No, the CT scan was not repeated, just chest X-ray.
Okay, so but you could see the initial changes on chest X-ray.
Yeah, the chest physician loves chest X-ray, so the chest physician is the one who actually asked for the chest X-ray.
Yeah, I mean, if it's a 70-year-old lady who has had such, I may consider actually using ribo because it's like it's easier to taper. I don't have to purposely order her 100 milligrams or something like that. I can maybe start her on like, like 2 or start 1 tablet first, and then later after a week go up to 2, that sort of thing. And then so I would probably in this case restart because it's a short duration. And she's improved, but probably switch to ribo just for the ease of tapering it.
Okay, thank you. Okay, so she was changed from palbociclib to abemaciclib, but at 100 milligram BD with the same hormone. And she did not have any recurrence of the pneumonitis, and beautifully, she had no diarrhea as well with the abema. So she was reevaluated after 3 months of abemaciclib, and indeed she had very good response in her primary breast tumor as well as her lymph nodes and also the bone metastases. So now she's already 7 months on the whole total CDK4/6 inhibitor and AI. And this time she presented with right-sided leg pain, bilateral leg edema with more red leg to left, more reddened skin there. So she had a Doppler ultrasound which showed that she has a deep vein thrombosis affecting her external iliac vein to the popliteal vein, and she was started on an anticoagulation agent. So because this is because of the DVT, I was afraid about recurrence of the tumor. Then I just reassessed her earlier. So I did a reassessment PET CT scan, and true enough, there was progression in her bones and breasts, as well as new metastasis in the liver. She didn't have any liver metastasis before that. So sorry, at this juncture, okay. So now, this is a 70-year-old lady, and the fact that she progressed really fast on a CDK4/6 inhibitor, something that we do see, but not that common, right? So, Asnal, would you rebiopsy her, or do you just change to fulvestrant plus fulvestrant, or do you rebiopsy her and try to see if you have, if the patient has developed any mutation? Asnal?
because it is a very fast progressor, so I would consider getting a new biopsy if it is safe enough to do a biopsy, and then check for any other mutation, especially ESR1 mutation that that making the patient
Resistant.
quite what we call not responding to the hormonal treatment as what we expected. Yeah, I would actually consider a biopsy of the lesion.
Okay, agree. How easy is it to get a biopsy of the liver metastasis in our setting now?
Sorry?
How easy for, I mean, if you were to rebiopsy, right, would you take from the breast or do you take from the new liver lesion because it wasn't there before? So now you have a liver lesion.
I would actually think of liver lesion, and then if that is easy enough to get a biopsy after discussion with my IR. So looking at the lesion is quite periphery, so I do think that it is something that biopsyable.
Okay. Darren, may I get your opinion with regards to rebiopsying? Is it pretty easy and pretty fast to get somebody to do the biopsy for us and then the results and all that?
Thanks, Mas. I think it's an option, certainly. I would probably even go for the breast rather than the liver in this case because of the fact that most of my patients do not like having a biopsy that has risks involved. And I'm more conservative a little bit about, side effects and problems with the procedure. So I would probably go for the breast, and if it's a breast, it's pretty fast, pretty easy, no sweat, and probably get a PIK3CA. I'm sure Esna wanted to say that as well, to do a PIK3CA. I think that would be the number one apart from ESR1, which we don't really have access except in clinical trials. But also, if you want to do more analysis. But if you argue against doing a biopsy, I think that's fine as well, because she did progress at 7 months, so she'll be officially secondary resistance rather than primary resistance. So I think you have a few choices here. Thanks. But I think it was really good for you to do the PET scan when she had a thrombosis, because as we all know, abemaciclib has a VTE risk as well. So you could easily just put it on a drug, but I think you did the right thing by just reassessing everything. Well done.
Okay, so she had a rebiopsy of the liver and it was a metastatic carcinoma from the breast. It was still ER and PR positive, and HER2 is actually now 1+. It was HER2 0 in the beginning from the breast. So she's also PIK3CA negative. The germline BRCA testing was not tested in this patient, and NGS was also not done in this patient. We discussed, but she was not interested at that time point. So just to highlight that in our patient population where we treating them for this, this group of patients, you can see there, at least 10 to 12% of the patients who are what we call fast progressors. So they will have an event as early as 3 months from when they start to be treated with either CDK4/6 inhibitor with hormones or not. So this patient is around there, about 6 to 7 months like that. So these are the patients that I would think that we would need to know why. So that's why I discussed the NGS with her in case she wants to see if she has any, mutation that we can target that is probably different from any other patients out there, because like I mentioned earlier, she's de novo, right? So that's basically where we are, where she has here. So there's always a concern about whether she is going to have a shorter response to a second hormonal treatment after this. So now, since she is somewhere here, right, and she has had biomarker tests done and she didn't have anything there. So I didn't check for ESR1 because I don't have that test in my hospital at that time point. So now, if you consider her refractory, right, and if she's refractory and she's HER2 low, because she's ER positive HER2 low. Would you actually consider her here where she would have treatment with TDXD, if she would have treatment with chemotherapy or with pneumonitis? And we know that TDXD may cause pneumonitis. Would you attempt it in her? She refuses chemotherapy. So the next thing that I have now is to give her fulvestrant alone, which we know the response rate is not, superior in such a patient who progress really fast. And I've used fulvestrant plus everolimus before, but yeah, just interesting to find what are your thoughts on this. So maybe Doris can give your opinion. Doris,
Yeah,
Doris?
yeah.
So this is looking at the guideline that we have.
Yeah. In this case, I mean, obviously, based on the guidelines, it would be very reasonable to consider because of a HER2 low status, right? You can also consider the trastuzumab deruxtecan. But I think rightly so, because of the history of the pneumonitis, which happens so rapidly, right? That is something you would be worried about also. If I had a 70-year-old patient who kind of had like a 7 good months of CDK, I actually personally may consider just giving her fulvestrant, kind of like wear it out, kind of take the thing and see whether potentially I can give palliative radiotherapy to the bones or whichever that is symptomatic first, or potentially later consider some local therapy to the liver if it's suitable. Yeah.
Okay. May I ask Anna, what would you approach at this juncture, given her issues?
Yeah, so I think at her condition, so I would consider at first, I will think about the low dose chemotherapy single agent. So, but in view that she is, I think she refused chemotherapy, I would consider, I think the latest medication, the deruxtecan. So, but still we have to be very, very careful in terms of monitoring for the pneumonitis.
Right, agree. So this patient actually, she wears a spine brace, and when I discussed fulvestrant with her, because I actually wanted to try fulvestrant and everolimus because I've used this before and it did work in one patient. And she said, "Doctor, you want me to open this and for your nurses to inject onto 2 of my buttocks?" It's an elderly lady, which she's quite cute lah. I mean, she tells her mind, and she's thinking, I'm going to open my spine brace when I come and do, and she just like she doesn't want it. So then we discussed TDXD with her and the fact that I'm going to monitor her very closely for pneumonitis. So she did actually have the treatment with TDXD, and she has had that for at least 4 cycles now. So I gave her 200 instead of 260, I think, which is a dose, because I just give it at probably around 75% dose. And she did actually not have any pneumonitis. She has very few side effects on TDSD, just some grade 1 transaminitis. So in terms of her response, right, as you can see there, her liver metastasis has resolved completely. Her breast lesion is actually stable, but she did have a progression in 2 spine metastasis areas. So it's like a mixed response. So what I did was I just gave radiotherapy as what you all had suggested to the local areas, and just continue her on the TDXD. And then I will do a next scan at about 6 months TDXD in September 2023. So that's the end for the first case, and thank you for your opinion. So maybe I can get Doris to share her case. Doris, can you share her case so that we can discuss? I will stop share screening now.
Mas, since Doris is doing this, she's got it. Okay. I just wanted to comment early on that case very quickly while Doris is doing this. That DB, doing deruxtecan up front without chemo is obviously, just for the audience, that it's not an approved way of treating at this moment. and we're waiting for DB06 to confirm whether we can use deruxtecan before chemo. That's all I wanted to say. Thanks.
Okay, so I actually have this lady. She's Madam YB. She's a 54-year-old lady who's postmenopausal, and she's got a twin sister with a history of breast cancer. And her sister's breast cancer is ER positive. So it's just a joint case. The first half of treatment, this patient is actually treated in KL. So she's got first diagnosis of left breast cancer in 2003 at the age of 35. And at that time, she was either stage 1 or stage 2. There's no record from her and she wasn't really sure, but she was ER positive and HER2 negative. She had a left mastectomy and an implant with axillary clearance, followed by tamoxifen and radiation. So I wasn't sure why she had her radiation, and she also wasn't sure. But she completed 5 years of tamoxifen, and in 2020, actually, she presented with a right breast lesion. And she had an excision biopsy done. It was IDC grade 2, ER/PR positive, HER2 was 2+, FISH was negative. At the time, she had a CT scan which showed multiple very small volume lung, bone, and liver metastases, and was not on any visceral crisis. She was actually started on palbociclib, letrozole, and denosumab, and at that point of time, she wasn't keen for any BRCA testing. So this is a 54-year-old lady with the symptoms here, and she actually progressed after about 1 year of palbo and letrozole. She had initial response followed by stable disease for about a year, but in September 2021, she developed progressive liver metastases. So you can see here with my arrow here, you can see this area here, right? And you can see the PET uptake in this area here. So the question here is, what is your expected duration of response? I think Mas asked a very similar question, but in this case, what would your expected duration of response be? Is 1 year something you would expect? Maybe we start with Esna, maybe?
Hi. So usually when patients have a good response initially, from my experience, the response lasts quite long. So similar like what we saw in the landmark study, 2 years, I would say the average number that our patient usually can last on the treatment. And then those who are fast progressor, they progress quite fast as well within the first 6 months. So in this case, 1 year is not the, I would say not the typical duration that we will see in our patient, but we do have patients who progress after this period as well.
Yeah, so I mean, I agree. For her, kind of felt a bit off for her to have progressed. So what would be next? Actually, so we got her previous biopsy tested, and actually she turned out PIK3CA positive. And so she was started on alpelisib, fulvestrant, denosumab. So this is very standard. I mean, there's nothing much to debate about. We know what the next step is. But she had a very stormy period with the PIK3CA actually. So she had an initial dose of 250, developed severe hyperglycemia, grade 2 lethargy and diarrhea, and multiple interruptions actually. So although her period of time, she had it over a few months, but she actually had a lot of time where she had to stop in between, despite reducing dose to 200 milligrams. And finally, she actually complained of grade 3 nausea, lethargy, and interfered with her activities of daily living. And so patient actually decided that she wanted to stop her alpelisib. So the question is, do you have any challenges managing patients on alpelisib? So, I mean, I don't have a lot of experience with alpelisib, so maybe it'd be good to discuss also, and also for trainees, it'd be something good to see. And do you see a higher discontinuation rate in our population? And any tips to overcome or improve this? So maybe Mas or Darren or Anna, anybody? I already kind of put Esna on the hot seat just now.
So alpelisib is not a drug that we like to give to our patients because of these toxicities, right? So maybe I can draw my experiences in either giving my patient fulvestrant plus alpelisib for those who are PIK3CA positive in the clinical setting. I also have study patients who are on the EPIC-B3 and EPIC-B2 clinical trials. So EPIC-B3 is for triple-negative breast cancer. We give alpelisib plus chemo. And for EPIC-B2 is a clinical trial where we give alpelisib plus Perjeta and Herceptin. So across the board, right, when we give it with fulvestrant in the clinical setting, we want to give 300, but we often cannot give 300. We would always studied low. So for the EPIC B3 and B2, they are actually studied low, 250. So when we studied low, the likelihood of getting the hyperglycemia is lesser, and also that they don't get it so fast, like in the first few weeks of taking the drug. The second and third thing that I get with alpelisib is rashes and stomatitis, of which because of the clinical trial, the protocol, right? So as others, I use the Piriton, I use the lopromide at the first instant of prescribing the drug. It's only the hyperglycemia that I have to refer to my endocrinologist to manage if it becomes you can't handle it. But otherwise, if you start giving them the medicine, is usually controlled. Most of the time we have to stop, and we don't see beyond that because most patients will progress after about half a year usually, in my experience. Maybe Darren can share his experience with alpelisib. Yeah, Kylie is actually suggesting, thank you, Kylie. Yeah, dose escalation week by week from 150 to 200 to 250 to 300, but we hardly give to 300, Kylie. Dose escalation of alpelisib to reduce the side effect as one of the tips to manage this drug, if not in a hurry, he says. Thank you. Yeah, but I don't do that. I'm not sure about Darren. Do you do that, dose escalation? Maybe you can try.
Yeah, I tend to start at the highest at 250 as you do, Mas. How did you find it with the Perjeta, Herceptin, and the rest? I would love to hear that. But before I just wanted to say that a couple of things is PIK3CA. There are a couple of mutations that do very well, and there are a couple of mutations that don't do very well. So it's also important to know the exact type of mutations. I cannot remember them. I always look them up, which ones are the ones that are going to do very well. Okay, and I've also, second point is with regards to the skin issue, I wouldn't touch on the hyperglycemia, which you have already. I think with the skin issue, I've begun prophylactic giving antihistamines and to prevent skin reactions, and I found that quite helpful on the advice of Novartis by Professor Hope Rugo and team. And there's a whole thing that you need to do before you even start the drug. So I found that quite useful for skin. Hyperglycemia, of course, working with your endocrinologist. Okay, yeah, over to you, Mas.
Okay. So that's about it. As for the toxicity with the chemo or Perjeta Herceptin, right? The EPIC B2, B3, and B4 has been discontinued. So the whole clinical trial has basically discontinued. So maybe that has something to do with the difficulty finding PIK3CA mutation in this patient population, as well as probably the side effects, which is not good. Okay, I think you can go on. Yeah.
Okay, thank you. So here is sorry let me cut this. Sorry. So here's being a devil's advocate here, kind of like for our discussion, right? So we know, like earlier we discussed about CDK4/6, and it's quite tolerable. Our patients, if they can tahan for many years, they go on it for many years, right? But there's just this really interesting article I saw. It's a real-world outcome in alpelisib, in metastatic hormone receptor positive breast cancer patient, and it was an experience, I think, in Roswell Park Comprehensive Cancer Center, and actually they compared their data for their patients on alpelisib and the ones in the trial data. And they did notice a higher discontinuation rate from adverse events. Because sometimes you see the thing and it looks like quite low, but then our patients are not tolerating it very well. And actually in their trial, it was a 47% discontinuation rate due to adverse events. Their grade 3 for hyperglycemia is 53%. Compared to in the trials was anywhere between 25 to 33%. So it's like slightly more than, half. Diarrhea was 15% versus 4 to 7% in the clinical trials. And rash was about 30%. I mean, it could also be because in a trial, the volume of patients is much, much more, as opposed to 27 patients in a single center institution. But it's just quite interesting to see. And actually, when you look at the SOLAR-1 at BILEAF trial, the discontinuation rate for adverse events was actually 3 to 4% only. as opposed to this trial, 47%. So assuming that we also have low volume patients, out of every 2 patients we see, 1 may actually stop because of adverse events. So I just thought it was just very interesting to put up because of this patient. So what happened was patient was unable to tolerate her alpelisib. Then she had a PET scan and the liver showed liver predominant disease, which was stable. So what will you do at this point? So she cannot tolerate alpelisib anymore. Her PET scan shows liver predominant disease. So you can see here you can see the liver. This is a large cystic lesions with smaller cystic lesions here. Her liver functions were still quite okay. So at this point, what would your options be for her? Will it be fulvestrant only, fulvestrant plus an mTOR inhibitor, exemestane plus mTOR inhibitor, chemotherapy, local therapy? You know, would you biopsy? What will you do here at this point? Mas?
Oh, if it can be biopsy, I would love to biopsy it, because you only know that she's PIK3CA positive, right? We do not know any other mutation. I mean, she was young when she had the cancer diagnosed, and she has a twin that has cancer. So I would biopsy and probably also look for germline BRCA mutation in this patient.
Okay, so at this point, actually, she wasn't biopsied yet. She was tired. She was fed up with all the toxicities from the, the alpelisib. Okay, so you have to understand the, so what happened was actually she received chemosaturation ×2, and actually was stable for about 5 months from May to August 2022. And a PET scan in October 2022 actually showed new liver lesions with mild increase in liver enzymes, about grade 1. So you can see here in May, right? You can see the PET avid lesions here, right? Post chemosaturation in October, you can see actually, unfortunately, she developed a biloma post chemosaturation here. So it's just an extra hepatic collection of intrahepatic collection of bile. And then you can see here the new lesions in October, right? Over here, which was, you could actually see a faint lesion here, but actually in October it's more obvious, and actually a new lesion here. So this is also a new term for me, actually. I think Mas brought this out, chemosaturation. Also, first time I heard from her. Then when I spoke to my interventional radiologist from this chap from GH, apparently it is something. So it is very similar. They call it transarterial chemosaturation. It's very similar to TACE. The difference is TACE is actually very localized, right? They go all the way to one, and usually they reserve it for like limited lesions, in either one lobe or something. And for TACE, the chemoembolization is a permanent chemoembolization. As opposed to chemosaturation, basically what they do is, it's very similar, but they can use it for perfusion over the whole liver. So it doesn't have to be in one area. It can be in one lobe. It can be a whole liver. And the chemoembolization is actually temporary only. It is a very transient, using a different type of thing they use. So yeah, it was something new that Mas brought up, that I also heard. That after that, I spoke to a few interventional radiologists. So apparently this is a thing. I actually also found out that there's this thing called an actual thing called chemosaturation, which was pioneered in the University of Southampton in the UK. But it has a device, so it's slightly different again, but basically it's the same. Basically, it's called perfusing the whole liver and just soaking it, saturating it with chemotherapy. So she did have some response. She actually tolerated her chemosaturation quite well, but unfortunately only 5 months of kind of stable disease before we saw an increase. So thinking that initially there's these 2 lesions, right? What will you do at this point? Anna has been quite quiet, so I'm gonna pick.
Okay, so I might want to discuss with the interventional radiologist again. So whether there is other way that we can do the local therapy. So either is to do the radio frequency ablation perhaps. Yeah, so this is what I'm thinking about.
Yeah. So
what about radiotherapy? Just want to know. Anybody who want to do stereotactic radiotherapy to the liver?
I think we have to look at the volume of that to see whether feasible or not, and what is the latest liver function test.
Liver function, just a mild increase. Liver function, liver enzymes about grade 1 increase. Bilirubin was normal. The albumin was normal. So she's still Charles A.
So I might actually discuss with my colleague who is doing the SBRT, so whether this is feasible or not. Yeah.
Yeah. So Mars is reading my mind, huh? So basically, what happened? To think about possible, other local therapy, because only 2 lesions, right? So she had a MRI of the liver, but unfortunately, you can see the MRI is like a Christmas tree, all these little dots that wasn't picked up on a PET scan. So they were either too small or actually not PET avid. So at this point, I think local therapy probably is not very suitable, right, for her. So what's next? So we have 54-year-old lady with metastatic breast cancer, ER/PR positive, HER2 low, PIK3CA positive. She progressed on palbociclib and denosumab. She was unable to tolerate alpelisib, fulvestrant, and denosumab, but had stable disease, and she failed after 2 cycles of chemosaturation. So spoke to the interventional radiologist. He feels that because of the large biloma and also the area, it wasn't actually suitable for TACE also, because the risk of infection and a risk of jaundice. So at this point, our options, could it be still further endocrine therapy, chemo, trastuzumab deruxtecan because of the HER2 low, NGS? What do you think, your options? So maybe the panelists, back to us now. I'll take turns, I'll be the fair teacher.
As now,
Sorry, my line, I was booted out just now. What's the question again? Sorry, what's the
so yeah. So the top part is just a summary of the patients, right? So in this situation, what would you offer the patient at this point?
So I was trying to ask, I'm not sure whether when I was booted out just now, anyone asked, during the treatment of, when you stopped the treatment and then was given the chemosaturation, is there any systemic treatment given as well? Is the fulvestrant continue?
No. Patient was fed up from all the injections, fed up from the hyperglycemia and things, so didn't want any of the alpelisib or fulvestrant at this point.
Okay. All right. So in this case,
patients, she may still be sensitive to fulvestrant.
So still sensitive to fulvestrant. Yeah, I will say.
That's what we think about.
Yeah, I will say, yeah, I was thinking of giving fulvestrant, but looking at the liver mets, I don't think single agent fulvestrant is a good idea. So whether she is okay with the idea of getting combinations of fulvestrant with everolimus. Otherwise, chemotherapy is also an option, looking at how big the progress, how fast the progression in the liver. So it is also impending crisis on the liver part. So chemotherapy is also something that I would discuss with patient.
So if the patient is agreeable for chemo, what will you offer her?
She had chemo naive, so I would say taxane-based chemotherapy would be my option.
Okay. So yeah, patient agreed for chemotherapy, but oncology is never straightforward, right? So what happened is, this is the beginning of a series of unfortunate events. So this is about near election time. So patients say, I want to have chemo right after election. That was like a week before. But admitted on the night before election, 18 November 2022, history of lethargy and shortness of breath for 1 week. Ejection fraction was 35% only. So basically, I wanted to show you was look at the x-rays. She presented with shortness of breath to the casualty department. Saturation was low. X-ray actually showed bilateral, kind of like patchy opacities on the perihilar lesions of the lungs, and the CT scan showed acute pulmonary edema. Further investigations showed that her ejection fraction was only 35%. We don't know the cause actually. The brain natriuretractate peptide was very high, 4,000 plus. HP was 7.7. So she was treated as acute pulmonary edema by our respiratory physician and also by the cardiologist in the CCU for almost 2 weeks. Would you change your treatment plan now? So she's well, 2 weeks, at the end of 2 weeks, she is discharged. PS is about 1, ejection fraction improved from about 30 something to about 40. Still
Yeah.
Esna?
Well, then I'm a bit worried if using docetaxel with all this pulmonary edema. I'm thinking of maybe something else, a weekly paclitaxel is maybe more tolerable for patients.
Yeah, so actually the plan was actually to give her EC, very old-fashioned. I wanted to give her EC actually, but not with that. So like you rightly said, we decided to actually give her paclitaxel, and the reason why I added carboplatin, at that point she wasn't still ready to do her germline screening. Somehow very hard, and she's a relatively young lady, but it's very hard to convince her to do the thing. So I added a carboplatin thinking potentially that, she may actually be BRCA positive because of her sister bilateral breast cancer, and it was a twin sister. So she had a very good and it was weekly paclitaxel. So it was something like the train type of regime. So she had initial response in the tumor markers, but then started to increase. Actually, after cycle 2, we started to notice her tumor markers increasing again. Her liver functions, her AST, ALP, and gamma GT came up to about 1.5 times the upper limit of normal. But her performance status improved, and she was actually PS0. She started hiking again. She gained weight, but that's mainly more because her cardiac problems has actually been controlled. So she's asymptomatic. But if you can see here, the CT scan on the liver from November 2022, right, before we started the chemotherapy, and in April 2023, you can see actually there's a very big difference in terms of the liver disease. I mean, the sheer volume of liver metastases has just kind of increased over a period of 5 months. So, I mean, what would you do at this point? Darren, maybe? Or
Thanks, Doris. Can I just make a few comments? First, well done for not giving her deruxtecan. Again, as I said, it's only a DB06 and we haven't got that data yet. And if we did it for this lady, I think we killed her because her heart failure and the pneumonitis and everything will killed her. So well done for that. And secondly, with regards to BRCA testing, perhaps we could discuss with her somatic testing of all these mutations, which may guide us to say that she has germline. Maybe that would have helped if she didn't want to have a blood or saliva test. And then with regards to what we would do at this stage after chemo and good combination chemo, and you've only given her 4 cycles, is that right?
Yeah.
Not a lot, and she's doing quite badly already, although clinically still well. And I think at this stage, you could consider a different chemotherapy option. You could consider going back to fulvestrant with everolimus, as you pointed out earlier. Although I'm not sure whether she's in visceral crisis now, but you have to look at the blood test, I suppose. But I suppose we've got to change the chemo. We've got to try something else. Eribulin comes to mind. Quite simple, quite easy. Capecitabine, vinorabine, other options. I think eribulin would be an option of mine. Yeah, thanks.
yeah, so, being our Asian patients, when they're in the brink of, a progression, liver about to fail, okay, then they start to agree to all those things. So finally, she's agreed. But by that time, I said, why don't we just do a liver biopsy and do an NGS? So that even if you don't want to know your, germline mutation status, we will probably know what your somatic mutations are. And so before that, we did a staging, and you can now see she's also got multiple kind of very small brain metastases, okay, but asymptomatic, but multiple. I mean, I think I could count at least 8 or more, right? But they're all asymptomatic. So here, I think just now Darren already talked about it already, but with the brain metastases, then the question is, should we manage the brain metastases first, or will it matter? But I'll just kind of skip and let you know that she's agreed for an NGS so I'll show you an NGS report. But prior to that, what do you think about the brain metastases, Mas? Is there anything you would do for the brain or not?
Well, because those patients who have ERPR positive, HER2 negative or HER2 low, right? They, it's uncommon for them to have brain metastases, but this patient has heavy disease load. So it's very interesting to see what would the NGS show us. But if the brain metastases are many and it's symptomatic, then of course I would treat it. I mean, I saw some probably less than 5, right? Doris, the brain metastasis.
I show you the one that you could see on, I think 1, 2, 3, 4, 5, 6, at least 6.
Yeah. So if there are many, then yeah, if there are 5 or 6, then we can, if tiny, then we can still give gamma knife. Other than that, if let's say the gamma knife is not available, then we just give whole brain radiotherapy. After all, you're not gonna think that this patient will have cognitive issue because she's really progressing, right? So yeah, I would just give it for symptomatic control. Then want to see what is the NGS finding. Maybe there is some, a variant allele frequency for BRCA1 or BRCA2 that is more than 50%. Then we know, oh, this is probably to have germline BRCA.
You'll never be so easy. If not, we won't have this presentation. But anyway, so yeah, I mean, I agree. So I discussed the patient and I told her, look, just because you can do something doesn't mean you have to do it. I mean, just because I can give you SRS to 20 lesions doesn't mean I should do it, because I think at the end of the day, I think if the liver fails, it doesn't matter what I'm going to do with the brain. And I think the liver will fail soon. So actually, we proceeded with the NGS and it came back red for a lot of things. Okay, so she was ESR1 positive, which is understandable with the history of a CDK4/6 inhibitor, but she was ERBB2 and ERBB3 positive for mutation. And also she had the PIK3CA mutation, which we know she had before. So the question here to our esteemed panelists is, in the presence of multiple mutations like this, what would your target be, and which would you think is probably the driver mutation here? I mean, I think we have gone beyond, at this point it's like anything goes, like we don't really have much evidence for anything. But we know that there's also FDA approval for Enhertu for the ERBB2 mutation in non-small cell lung cancer. But can we extrapolate this and use it for our breast cancer? And will it matter if she's got now an ERBB3 mutation? So what are alternatives here? So I think everybody can probably give an idea here. I won't pick.
I think for her, because of the ERB2 mutation data for breast, we have the fulvestrant and naratinib study, right? But that would be something that we could explore. And the other possibility would be any of the oral agents. Sorry, not oral agents, single agents. Otherwise, I cannot think of anything else because she has so many mutations and her liver is so bad. What about the rest?
The rest will come down. Maybe Darren first, then we'll Asnal, and then
there are a few hands put up. I don't know whether you want to ask.
How do we? Yeah.
Ibtisam has raised her hand. I'm not sure whether she.
Yes. Feel free to contribute. Yes.
Yeah. Yeah, Ibtisam. Ibi. Do you want to ask a question? David asked about the gene copy number of the ERB2 and ERB3.
Sorry?
Do you have it, Doris? He asked about the gene copy
Where's
number.
the question? The answer?
The Q&A down here. So from David, he says, what are the gene copy numbers of the ERB2 and 3 mutations?
Oh, more detailed. Oh, sorry. You mean the detailed one? I actually ticked this one not only because I looked at it and I was like, oh crap, this needs a molecular scientist to. Is there in a different?
It's written as mutation detected. So this is like a point mutation of the
it's not,
ERB2
I don't think
and
it's an
ERB3, right? Yeah. So gene copy number will be the gene amplification, which is not actually having here lah. So it's okay. I think we can move on. But what about Anna and Asnal with regards to
Anna, Asnal, Darren?
Drew?
This is No marker from Cikgu. Everybody gets 100% for participation.
Do you want me to comment then? I think there are a few things here. She's first of all got pulmonary edema with weak heart. So I think your anti-HER2 treatments, even if you're going to claim that HER2 will work for mutations, would not be very suitable anyway, because she's got this weak heart problem. PIK3CA we already know about. ESR1 research.
What about neratinib and fulvestrant?
Neratinib and
Neratinib
fulvestrant.
for the ERB2 mutation.
Okay. I'm not a keen fan of neratinib. She's got, I think Doris has said she's on the brink of liver failure. So, you know, in fact, I don't think this is very useful to NGS at this stage. I would be more keen to go for if SRS is necessary, and then plus and minus chemo with Halaven or something like that initially. And then once she's better, maybe look at the ESR1 side of things and try and do fulvestrant with everolimus or fulvestrant with something else, or one of the new ESR1 mutation inhibitors. Thanks.
Yeah, I mean,
Doris, I think we have to move on.
Yeah,
sorry,
just want her ejection fraction. Actually, after we did this, when I got the cardiologist have a look again, ejection fraction is 55%, and he still doesn't know what was the cause of cardiomyopathy. But she's now performance status 0, and ejection fraction is 55%. So yeah, I'll just kind of quickly move on a bit. We're almost done already. So, I mean, like I said, anything goes at this point. So just a few things. The phase 2 MUTE-HER study showed, like what Mas said, neratinib versus neratinib in combination with fulvestrant actually showed a clinical benefit rate of 38% in fulvestrant treated, 30% in the fulvestrant naive, and the ER negative cohort was a 25% clinical benefit rate. And those patients who actually progressed, they repeated the HER2 mutation status, and they found out that actually another extra 5 patients developed a mutation at that point. But regarding the HER3 mutation, the SUMMIT trial, which was done, not specific for breast cancer, but for HER3 mutations, they showed that pre-existing concurrent activating HER3 mutations were associated with poor treatment outcomes in patients with HER2 mutant breast cancer. And actually preclinical data in the HER2 and HER3 double mutant cell lines shows that a combination of PIK3 inhibitor with neratinib overcame the neratinib resistance, because HER3 apparently based on the pathway renders the patient not sensitive to neratinib and the fulvestrant combination. So, but back to alpelisib, which is something that is very difficult to convince this patient on. But I think based on that, like mentioned earlier, neratinib fulvestrant is an option, but because of the HER3 mutation, it's making it a little bit complicated for patients. Quickly about the ESR1 mutation, we know that the incidence of ESR1 mutation in patients who receive previous therapy with AIs are actually very high. So this combination, I mean, not very high, but it is a reasonable, anyway, about 30%. So these are just from the MONARCH trials, Emerald trials, Sophia and Bolero trials. And you could see that actually the frequency of ESR1 mutations in a patient's pre-treated with CDK inhibitors is anywhere from about 26 to about 48%. So average to about 30 to 40%. And we know now that there is an option for elacestrant, which you can see in the Emerald study. Although everything looks very nice and you know, significant, but you have to see that actually the duration of progression-free survival is actually 3.something%, 3.78%. So whether it's something statistically significant, is it something that is, you know, clinically significant or not? It's something that we need to make our own judgment. But because of the Emerald trial, the updated ESCO guideline actually suggested that to aid in the treatment selection, they suggested routine testing for emergence for ESR1 mutation if the patient recur or progress on endocrine therapy with or without CDK inhibitor. So these are the potential options that was mentioned just now by Darren and Mas and Esnal and Anna, and just some trials to kind of support that. So just very quickly, I'll give you a plot twist and I'll finish, right? So what happened was this lady, final give you summary, she started on Enhertu, And she had a cycle 3 last week. Her cardiac function, cardiologist, I spoke to him again and again, was okay. We repeated the CT thorax. There's no residual lung finding before we started. So outcomes to be updated for this like promotion for future MOTB meeting, okay? But just to kind of leave you with something, 3 months ago, she complained of a left cheek pain with occasional white hard flakes in the saliva. What could this be? Anyone wants to guess? I'll pick Anna.
Candidiasis?
Sorry?
Candidiasis? No.
Pharyngitis?
Candidiasis.
Oh, candidiasis. Nope, it was hard. She had like show me, like keras like that, like cornflakes but white color falling with a cheek pain. So send her to a dentist.
Yes, I think
And
maybe
this is what you can see. She's got osteonecrosis secondary to the denosumab therapy that she had. So if you can see here, on the right side of the cheek, actually, you can see part of her, the jaw was already irregular. But very interestingly, you see on the left side, right, what you can see actually is the teeth has already come off, the teeth with its roots. The entire thing is actually just chipped off. So what she was experiencing actually was bits of teeth and the bone. It was falling off. Yeah, so just a quick one to end us with something lighter, something that we can do something about rather than these complex cases. Do you send all your patients for dental assessment before giving bisphosphonate therapy? In this case, would you still give her further bisphosphonate therapy? I mean, she hasn't had it for more than a year now. But if she develops bone, painful bone mets or hypercalcemia in the future, is this preventable or is there any treatment? So maybe just to summarize it, maybe round up from each of our panelists, because bisphosphonate is so widely used in our setting.
Okay, so that we don't waste time. So I do actually advise my patients to have the dental assessment as well as like monitoring while they're on the denosumab or on Zometa, right? But whether they actually do go or not, that is something that sometimes we forget to ask them. The patients that I have seen with osteonecrosis after prolonged zoledronic acid treatment are not many, but they are usually after like a few years, like 2 years, like that. Not many. I would say probably in the count of a hand, less than 5. Maybe the others can share.
Yeah, usually I make a practice to refer the patient to the dental before we start, at least before we start, or in the worst case, maybe after 1 or 2 cycles. Usually our dental appointment is also quite late, so we start with the first dose first. But I do saw 1 or 2 cases with osteonecrosis, but fortunately it is not very bad. So with conservative treatment, without any surgical intervention, it recover after we stop the treatment. So I do not have very bad osteonecrosis in my patients, fortunately. But to answer your question, whether I would start again or give again denosumab in the future will be depending on whether it is because of malignant hypercalcemia. If it is malignant hypercalcemia, I would, because I don't think that the longer term effect on the jaw would likely matter. This patient have a poor prognosis to begin with, so I would give. But if it is for skeletal related event in asymptomatic bone mass, then I don't think I would continue.
Darren, Anna, anything? Final word?
Okay. Thanks, Doris. I would definitely refer everyone for dental assessment before, and I think we've been played a fast one by the pharmaceutical industry. Remember, we were told have to give monthly, then after that we heard from Jewish data, 3 monthly, then after that 6 monthly. I think if we give it not so frequently, we see less of it. So, and not so bad as Nurse said. So I think we should be less rewarding of drug companies in the frequency as we give it as well. Thanks.
Anna, last words. You're the final person to wrap us all up.
I agree with Dr. Darren. So actually that has been my usual practice. So sending the patient for dental assessment before we start on the therapy. So and also we actually also would like to follow up with the patient. So if there is any complaint, so we would like to pay attention to that. So far, yeah, we give like if the patient is stable, so we may give like 3 monthly the interval to reduce the
Okay.
risk.
Yeah.
Thank you.
Okay.
And sometimes you will also consider drug holiday. They're stable, then just stop it for a while and then just
Yeah.
Okay, yeah. I
Okay.
think
So thank you, Doris, for your excellent presentation. There's so much learning that we can get from there. So I think if we have 6 minutes left because we're supposed to end at 6:30, but because there are a lot of hiccups when we started just now, with people keep being booted out and so I wonder whether you guys want me to present the third case, which is actually quite short. If you guys want, I'll proceed. Otherwise, I will just end it here. What do you guys think? It's probably going to take about, is it okay to just probably 10 minutes? Yes, please.
Yeah.
Okay, so
Yeah, okay.
So I'm going to share screen now to the next case quickly. Yeah. So, okay. So is a young at the Johns Hopkins Hospital in the US. So she was working there. So she's diagnosed with right-sided stage 2 IDC. T2, her tumor was 3.5 centimeter, no lymph nodes, grade 1. Her PR was strongly positive and HER2 was 0. So she was actually evaluated with bilateral breast MRI, and she had multiple masses on the right as well as the left breast initially. So she had a family history of liver cancer in her uncle, no comorbidities, and then she subsequently was treated with right nipple sparing mastectomy with breast reconstruction, and then she was also subjected to mammaprine testing, and the result was luminal A, low risk. I did to forgo adjuvant chemotherapy for her because of the mammaprine test result and the clinical low risk tumors as well. And a month after her surgery, she was started on adjuvant tamoxifen, and she was doing well for about a few months, and she actually managed to return to work. And my question to the panelists, because this is a young patient, young Asian patient who has, yes, low risk disease, but she's 29 when she was diagnosed. So how credible is actually mammaprine for our young premenopausal patients with this tumor? With do you rely on the mammaprine test result in managing your patients in the clinic who are young like this? So Doris, yeah, can I get Doris? Can you hear me?
Yeah. So I think personally I've never actually used a mammaprine testing before, but from what I'm gathering from what we read and things like that, we kind of need to take it with a grain of salt with when you're doing mammaprine for young premenopausal patients, because the aim of doing it is for a predictive testing in it to see whether should we give the patient treatment or not. But if I'm not mistaken, it's not recommended as a predictive tool, more of a prognostic that thing rather. So if I were to do for a premenopausal low risk, I would probably use Oncotype at this point. So yeah.
Have you used any for Oncotype for premenopausal patients, especially if they're really young like this? Maybe Darren, if you can take that, or Esna or Anna. Have you seen anyone doing Oncotype DX?
So I think you're right here, and this question is loaded with learning. I think Oncotype DX, even so, in someone with under 30, under 35, the number of patients are small, Taylor X,
Yeah.
wherever. So we really have to take the data with a pinch of salt in very young people. And we know that these are aggressive patients, or aggressive tumors rather than aggressive patients, sorry. Thanks.
Thank you. Okay, so to go quickly, just wait. Okay, sorry. So this is the NCCN guideline for invasive breast cancer. You can see here that for the Mama Prince study, right, the predictive value as per what Doris has said is not determined, is prognostic, yes. Okay, and for the Oncotype DX predictive and prognostic, okay, although it is actually in the consensus guideline, but I guess, in my opinion, our Caucasian patients has probably different genetic characteristics, I would say, because most of the data that were in the Oncotype DX or Mama Print came from maybe largely Caucasian patients. Although there are some validation of the Oncotype DX with Japanese, there was a Japanese group with validation, but the number is actually small. So I guess that is not mapping really to our really young Caucasian patients. So I agree with Darren there. Okay, so this patient, she was taking 6 months of tamoxifen, and in March 2023, remember that she had surgery in September. In October, she was started on tamoxifen. So she noted a palpable lump at the right metastatic and recon site, and the ultrasound done showed a superficial 8 millimeter mass. That was what they thought was fat necrosis, she then, because she had this reconstruction where she was supposed to replace her expander, so the doctors sort of put her on a reconstructive surgery to replace the expander with implant, and then they just decided to sort of excise the fat necrosis. And this was actually a local recurrent of about 5 millimeter invasive ductal carcinoma. Morphologically, it was similar to the patient's initial breast primary. So while waiting for the review at MD at Johns Hopkins of her case, they want to do couldn't believe that this is a recurrence. They're thinking, oh, this is probably like a residual tumor, not residual, sorry, a tumor underneath the skin that was not excised in the very beginning and all that. So while waiting for that, she developed another recurrence at that same site where they excised the 8 millimeter tumor, right? And this one is about 1.5 millimeter. So this was fortunately excised with a wide margin, and it has the same biology. At this time point, I think she grew tired, just like Doris' patient. So she returned to Malaysia. She just chucked. She was working there for 3 years. She just chucked and returned to Malaysia to seek further treatment here. So so now we have a patient that have like some sort of a local regional recurrent, that look at the whether this, whether we now want to treat this patient with chemotherapy. So this CALOR study, which is a study on patients with this sort of situation where they get a complete excision of the local regional recurrence, like. So in this study, the conclusion of the study was that the chemotherapy benefit was largely for patients who have hormone receptor negative local regional recurrence. And for hormone receptor positive patients, it doesn't support the use of chemotherapy at this time point. So for the panelists, right, would you give chemotherapy in this patient who are young, who have a recurrence very early on her disease trajectory? So maybe Anna, you can take that. Would you give chemotherapy, and what else would you do other than the chemotherapy? If you're going to give chemotherapy, what else would you do?
Yes, I would like to give the chemotherapy. So even though there is already data, I think not suggesting of the chemotherapy among the patient with ER positive. So I think we have to bear in mind that this breast CA, even though it looks like local disease, but actually quite a systemic disease. So I think very higher risk to recur, and also I think we worry about the progression. So I would like to offer chemotherapy and the radiotherapy as well after the excision of the recurrent nodule.
Okay, I agree with you with the chemotherapy. What chemotherapy would you give, Anna, at this juncture?
I would like to give the EC regime.
Yeah. Just EC only, no taxane?
Taxane, actually, depending on whether there is a lymph nodes positive, perhaps I would like to screen the patient again with the CT scan at least, or PET scan.
Okay. I want to, okay, sorry. So are there any other suggestion from the other panelists? She has had a re-evaluation, Anna. She doesn't have any other distant metastasis. She had a CT scan done prior to coming back to Malaysia. So at the time that she came back to Malaysia, from the so is fat necrosis common? Do you guys see that, or you know, are we? I mean, in my practice, I would say that if any young patient that has some sort of alarm after they have had a recurrence, I would be more afraid of recurrence, you know, and I would try to get my breast surgeon to see the patient as soon as I can. I do see fat necrosis, but it's usually not at the surface, not near the you know, the skin or the subcutaneous area. You will get it when it's as a bumpy lump on the breast. But maybe you guys can share with me your experience with regards to local recurrence following a breast and recon. Maybe Doris do you have any opinion, Doris, about that?
I've only seen one patient similar to this, but she was a triple negative young lady who had a reconstruction and then had something like this initially thought to be a sebaceous cyst less than a year after the surgery, right? But because she was triple negative, she had her adjuvant chemotherapy. And so we thought a sebaceous cyst excised it, turned out to be a recurrence, subcutaneous, just under the skin. So not the typical fat necrosis areas that we see also. I think the biology of such things, it could be like this dermal infiltration or those lymphatics in that area that is causing it rather than a true recurrence. But I think I agree, like at this point, you'll be very cautious if you see one recurrence because you don't know, because once they're under the skin, you don't know, it's no longer bound by the normal anatomy in terms of spread already. So I think I'll be really cautious in terms of, you know, the next question is, do you think the patient needs radiation?
Yeah, I had suggested radiation to the patient as well as the chemotherapy, as well as to consider ovarian suppression. But another thing that I wanted, sorry, I forgot to say that she's germline BRCA negative. Sorry, I forgot that aspect. But who would actually ask the patient to remove the reconstructed breast for easy monitoring? Because we don't have MRI like in John Hopkins, where they can do like very frequently. I mean, sometimes we do have MRI, but the reports may not be to what we expect, because it's not commonly done. So Darren, would you actually advise the patient to remove, or she's open to whatever that we throw to her?
Gosh, that's a difficult question for a man to answer. And I think it should go to one of my female colleagues to decide on that. I wouldn't force her. I certainly wouldn't force her. I'm not fussed. Yeah.
Yeah. Okay. Thank you. Anyway, okay. So we just go on now. Okay. So so she had the adjuvant radiotherapy to the chest wall, and then we discussed the chemotherapy. I think everybody agrees that she should have chemotherapy, right? She has 2 recurrences within less than a year. And which regimen, as Anna had earlier mentioned, I mean, I would give anthracycline and taxane. And now we have to discuss, because she failed tamoxifen, right? So we have to now think about her endocrine strategy, whether we want to give her ovarian function suppression and AI, or maybe we want to do ovarian function suppression and letrozole. But she's a young lady that, you know, she has a fiance, and she's also asking me about fertility. Any thoughts on that, Esna? She's saying that, you know, she would like to have children in the future. So how would you help her there? I mean, what do we have in our day-to-day, you know, practice, where when a patient wants to start chemotherapy, and then they would want to know about their fertility options? So maybe you can share your experience in clinic, how you deal with this.
May I know, Dr. Masra, is she a Muslim?
No, she's Chinese.
Okay, so I think in our setting, in government setting, we are quite limited in the fertility preservation method, but we do have a referral done to HUKM, which they quite a good onco-fertility center, and then they did come present to us, and then what are the options of fertility preservation that they do in their center. One of the I found out that they do ovarian tissue preservation, which I think something that not many centers are doing, especially in those patients that we want to start treatment fast. So we don't need to wait for the stimulations of the ovary. Otherwise, in patients who we think that time is not really a concern, then maybe oocyte preservation is also another technique to be considered. In a married couple, then embryo preservation, of course, is a valid option as well. All these are available in many private or university center, but I know ovarian tissue for preservation, from what I know, is only in HUKM so far, but I'm not sure whether is there any other center are doing the same thing.
What about Penang, Doris?
So I'm not sure if they have in Penang GH whether they have the ovarian tissue preservation, but here we send them to, because there are quite a number of fertility centers in Penang. So we would send them to the fertility center to discuss about preservation. A lot of times I see they do either the oocyte preservation here. And I think the gynecologists, the ones that we deal with, are quite open for discussion and things like that. So discuss. I think from the last time I get it, the procedure isn't long. It takes about 2 weeks, I think, for them to do the collection, the counseling, and also I think it's a reasonable time before we start treatment.
Yeah. So in this case, actually, I discussed one fertility center, which is a private center, and the patient was seen on the same day that I saw her. And then he started her on an AI, and subsequently on GnRH analog first. And I decided to give radiotherapy first in this patient because of this fertility procedure being carried out. So I only when that is done, because it can be done while the patient is having the RT to the breast recon area. So once this is done, only then I started the chemotherapy for her. So okay, so if there are any other, because we finished with the two cases by myself as well as Doris. So we are okay with, maybe we can have some questions if, let's say, any of our colleagues want to ask any questions, or if there anything that maybe Darren want to give any comments or anything like that to the cases that we discussed. And thanks, Darren, for pointing out that for the first case, the TDXD was given in the second line setting, so-called, because in this patient where 6-7 months and with 2 episodes of toxicity to the CDK4/6 inhibitor use, I like I mentioned, I discussed chemotherapy with her. She wasn't keen, and that's why the decision to do that, to give her the TDXD was done. So this is not in what is in the guideline, but something that the challenge that we face in our clinical practice, where we are faced with patients like this. You like thinking, is this endocrine refractory because she had 6-7 months of response only. But I'm good with any feedback or comments if you all have any.
So just one or two comments. One is that I would totally agree with you, whether or not she wants to have pregnant, to have a fertility treatment or not. I think radiation is upfront because she's got a local recurrence rather than systemic recurrence. And two, just to point out that there's an option whether or not someone should have chemo or not in someone with this kind of biology, with a luminal A. And if she definitely wanted to be pregnant later on and definitely didn't want chemo, that's fine. We can do OFS and hormones plus and minus. If you want, you can add in a CDK nowadays with the ribo data. The third thing is, if you're going to give chemo in the adjuvant setting, then don't forget POEMS data where you give a LHRH. Even if she doesn't want a child, to preserve ovarian function. Thank you very much, Mas Jura, for the job well done.
Thank you, Darren. So if there's any question or comments from the audience before we wrap up. Sorry. Stop share. Okay. So if there are no comments, we can end the discussion. It has been very heavy, I would say, very heavy. And I invite all of you to give your feedback or comments, because this is the first oncology tumor board for us. We would have a second tumor board on the 23rd of August with new range of panelists. So this one will be on early breast cancer. So please do come and join the discussion. Right. So with that, I thank you everyone, and thank you the panelists for your presence today, and Doris for presenting your case. Okay. Right. Thank you.
Thank you. Thank you, Dr. Mastura. Thank you,
Thanks.
everyone.
Thanks. Have a good week.